Everyone, welcome back to another episode of the High Yield Step 2 CK concepts on our YouTube channel. We'll be discussing Hirschsprung disease today, and this is our content outline for the day. As usual, we will define the disease in simple terms. So Hirschsprung's disease usually affects the large intestine or the colon. So during the process of the disease, there is going to be a portion of the colon missing certain nerve cells. Therefore, that part of the colon will not be able to perform peristalsis, or usually there's going to be impaired bowel movements that could lead to constipation. Let's delve deeper and talk about the pathophysiology of the disease. So first of all, there's going to be failure of neural crest cell migration, which is going to cause the aganglionic megacolon. So another name for Hirschsprung's disease is aganglionic megacolon. So now that affected portion of the colon lacking the neural crest migration is going to underperform. So since peristalsis is not being effective at that point, there's going to be stool accumulation in the proximal colon, and then there's going to be an obstruction at the rectosigmoid junction. So there's a picture here depicting the pathophysiology of the disease. So this is how a normal colon looks like. So there's always enteric neurons along the colonic wall, which propels or helps in propelling food in the intestines. So during Hirschsprung's disease, there's abnormal migration of these enteric neurons. So as we can see here, this is called the transition zone, where there's a low density of the enteric neurons. So because peristalsis is impaired along this portion of the colon, there is going to be stool accumulation in this portion of the colon. That's why this part looks very distended. Here are some of the symptoms. We are going to discuss them shortly, and also some complications that could result from this. So there could be bowel inflammation, perforation, enterocolitis can also occur. Okay, so now the signs and symptoms include delayed passage of meconium, more than 48 hours in units. So usually the question would describe a patient that hasn't passed stools for more than 48 hours. And in children and adolescents, it's going to present as chronic constipation. So delayed passage of meconium in infants or neonates, that's more than 48 hours. And then chronic constipation in children or adolescents. Also, patient might have poor feeding, and then there's going to be thin caliber of stools due to failure of the distal colon to relax. Also, bilious vomiting can occur when there is obstruction that is distal to the bile duct. So when obstruction occurs distal to the bile duct, it's going to cause bilious emesis in such patients. You will also see abdominal distension on examination findings. Most importantly, you have to know the rectal exam findings of this disease. So you are going to find increased rectal tone due to tight anal sphincter. There's going to be a positive squirt sign. So this refers to an explosive expulsion of gas and stool in the rectum during exam. And then there's also going to be absence of stool in the rectal vault from all the constipation that is going on. Also, due to straining from the constipation, there may be anal fissures and hemorrhoids that could cause a positive occult blood stool test. For the diagnosis, your initial diagnosis should be an X-ray, because first we want to rule out any form of perforation before we do a contrast enema to identify the site of the obstruction, or an anorectal manometry. So always do an X-ray first if you are suspecting Hirschsprung's disease, and then you can do a contrast enema to identify the site of obstruction. But for the gold standard or confirmatory test, you have to do a rectal suction biopsy, which will show absent ganglion cells on the affected portion of the colon. On imaging findings on the X-ray or contrast enema, you will see a narrowed rectosigmoid area. Also, there's going to be dilated proximal colon, which may or may not include a dilated small bowel as a result of the obstruction. This is an image finding, very high yield. So right here is the narrowed sigmoid colon, right? And right above it is the dilated descending colon. So this portion lacks the enteric neurons. Since peristalsis is not going on, all the stools have piled up in this portion, and the whole place looks distended. And then since nothing is getting through here, this place looks very thin and narrowed. So this is the narrowed sigmoid colon. So treatment of Hirschsprung's disease, we usually do a surgical resection of the aganglionic segment. So it's that simple. Surgery is the only choice here. So you just have to go in for surgery and then resect the aganglionic segment of the colon. Now it's important to know the differential diagnosis because meconium ileus and Hirschsprung's disease could have certain similarities. So let's discuss it. So in Hirschsprung's disease, it's caused by absent neural crest cell migration, but for meconium ileus, it's usually due to obstruction by inspissated stools. So this refers to hard, dry, difficult to pass stools. So it's important to note this difference. So Hirschsprung's is caused by absent neural crest migration. Meconium ileus is due to obstruction by inspissated stools. That's hard, dry, difficult to pass stools. So whenever a question is describing delayed passage of meconium or delayed passage of stools in an infant, usually you are thinking of these two differentials. So the cause of Hirschsprung's disease is due to absent neural crest migration, and the meconium ileus is due to obstruction by inspissated stools, which is hard, dry, difficult to pass stools. Now, the level of obstruction in Hirschsprung's is the rectosigmoid junction, whilst meconium ileus obstruction occurs at the ileum. During rectal exam findings, there's increased rectal tone and squirt sign is positive. Remember, we said squirt sign is when there's explosive expulsion of stools during rectal exam. But for meconium ileus, there is nothing as increased rectal tone or squirt sign on exam findings. Hirschsprung's disease is usually associated with Down syndrome, and then meconium ileus is a feature of cystic fibrosis. For Hirschsprung's disease, the meconium consistency is usually normal, whilst for meconium ileus, the stools are hard and dry and very difficult to pass. So also take note of this. Imaging findings will show narrowed rectosigmoid area and dilated proximal colon with or without the small bowel, as I showed you earlier. And then for meconium ileus, there's going to be dilated small bowel. You may also see microcolon or underused colon on imaging findings. So this is meconium ileus, and this is how it looks on X-ray. So there is dilated small bowel loops proximal to the obstruction. So this is the dilated portion that is being shown from this side to this point, from this point to that point. And then there is also microcolon seen in meconium ileus. So you can see that the colon looks very small in size because it's being underused. And then you can see some meconium plaques right here on contrast enema. So our first question says that a 6-day-old newborn is being evaluated for abdominal distension. The patient was born at term and the mother had no birth complications. The baby has poor feeding habits. Exam findings show a distended abdomen and there is an explosive release of stools from the rectum on rectal exam. What is your diagnosis? We have meconium ileus, necrotizing enterocolitis, intersusception, and aganglionic megacolon. So let's reread and mark out some findings that will help us diagnose the condition. So this is a 6-day-old newborn. Patient has abdominal distension, was born at term, no birth defects. Patient has poor feeding habits. So the exam finding is very important here. We have distended abdomen. There is also an explosive release of stools from the rectum on rectal exam. Okay, so just now we discussed from our differential diagnosis table that for meconium ileus, you wouldn't see an explosive release of stool from the rectum on rectal exam. Usually, we said that the rectal exam findings are normal in this condition. So even just with your exam finding, you can easily rule this out. Necrotizing enterocolitis sure can cause abdominal distension and poor feeding habits. But then on rectal exam, there is no explosive release of stools. We can also rule this out. Intersusception also has a normal rectal exam finding. so this can also be ruled out. So we are left with the option of aganglionic megacolon, also known as Hirschsprung's disease. So just take note that sometimes the question might not say Hirschsprung's, it can just say aganglionic megacolon, which is the answer of choice. So the answer was just based on the exam findings of explosive release of stools from the rectum. So whenever you see this in the question, your best answer is Hirschsprung's disease. The next question says, what is the most accurate test? So if you remember, we said rectal suction biopsy was the most accurate test or the gold standard for diagnosing Hirschsprung's disease. We do not do an MRI, a CT scan. And then contrast enema is part of the initial test that has to be done, but it's not the most accurate test in diagnosing the condition. This question says, what other physical exam findings may be seen in this patient? So we have absent jaw, we have a single transverse palmar crease. So Down syndrome patients usually have a single transverse palmar crease. So this is our answer of choice. The next question says that a 1-day-old baby is being evaluated for bilious vomiting. The patient was born at term and has not passed meconium yet. Exams reveal a distended abdomen. A rectal exam shows a normal tone and there was no stool in the rectal vault. Imaging shows distended loops of bowel with no rectal air. What is the most likely diagnosis? So we have neural crest migration failure, intestinal obstruction by inspissated stools, and we have intersusception. Here again, the rectal findings are the most important findings to diagnose the condition. So we are seeing that here the rectal exam shows a normal tone and there is no stool in the rectal vault. Imaging also shows distended loops of bowel. So like I said earlier, whenever the question states a patient who has not passed meconium yet, always know that you are thinking either Hirschsprung's disease or meconium ileus. So at that point, the rectal exam findings is the most important or accurate way to make your diagnosis. So for meconium ileus, there is always a normal tone, whilst for Hirschsprung's disease, there is going to be an increased rectal tone and a positive squirt sign. So always take note of that. We already discussed that for meconium ileus to occur, usually there's an obstruction due to inspissated stools. So you might not see meconium ileus, but this is the pathophysiology of the condition. So this is the right answer. So soon we have come to the end of yet another episode. I hope you enjoyed this lesson. We will see you in the next one.
Everybody got around it.